Welcome back, kids and coaches. And today, for your third video of the day, we're going to be talking about Chapter 13, which is recognizing different sports injuries. We'll also finish up later on today with Chapter 25, so we'll finish all that here. But with this, we are going to be getting into recognizing all the different sports injuries we're going to have. So with that in mind, there's going to be an awful lot of information here, but it's just going to be a general overview of these. We're going to go into a more in-depth discussion of each of these injuries individually in the coming weeks. So next week for Unit 6, Unit 7, and Unit 8, we'll be getting into all these a lot more in depth on an individual level. So right now we're just going to kind of go over this in a broad scale kind of definition here. So first things first, there are two classes of injuries we're going to be talking about. We're going to talk about acute injuries, and we're going to talk about chronic injuries. An acute injury is something that is immediate, short-term, happens right away. Acute injuries tend to be much more traumatic than chronic injuries, and that's going to be a big factor in what we're going to see in a lot of athletic-related injuries here. So a couple that we're going to look at: bony injuries, most common is fractures. We'll see dislocations or a subluxation, contusions or bruising. If you have any sort of soft tissue injuries, those are the ones we're going to look at as well. Sprains and strains, muscle guarding, muscle cramps. You wouldn't normally think of muscle soreness as some sort of a traumatic injury, but it does kind of fit into that, seeing as though it is like kind of micro trauma. And then nerve injuries, we'll kind of finish up with that on. Now, when you talk about any sort of fracture, there are multiple different ways you can fracture a bone. You know, when you say a bone is broken, that doesn't really tell you a whole lot of information. So if you say a bone's broken or fractured, I mean, yeah, we know that there's some sort of disruption in the bone material itself, but that can be, you know, anything from as simple as, you know, a little hairline fracture. If you had really even, well, this closed fracture would be the closest thing to it, but you can have a hairline fracture where it's just kind of cracked, or you can go as bad as this open fracture where there's a bone sticking out of your skin. So all different types there. The main trait that all these share is that they're going to require time being immobilized and non-weight bearing, meaning that you should have the like casted or splinted and not be using that limb that's broken. Now, granted, if something's broken, it's going to be pretty tough to use it because that's going to be a, you know, something that's going to hurt a whole heck of a lot. Now, this picture up here I have is an example of what's called a bone stimulator. What you'd use this for is if you had a bone break in a location where healing is difficult or your body's already having a difficult time healing. So for example, you've broken a bone in your foot there, so one of your metatarsals perhaps, you maybe have had it casted for a while and it still hasn't completely healed over the time it should have. You may use a bone stimulator, and you're wearing this for hours a day to give gentle vibrations to the bone in an attempt to get it to start repairing itself or to start forming new bone much more rapidly. When you talk about any sort of dislocations or subluxations, you're talking about a separation of a bone from its joint. Now, some of these are really easy to come by. If you look at your shoulder, so we have two pictures of the shoulder here, it's super easy to dislocate a shoulder. I mean, you could virtually sneeze the wrong way and your shoulder could dislocate. You know, you can even say pull on your shoulder and you can actually feel it partially sublux. So if you were to pull on your own shoulder, you can actually get that to partially separate from its joint there. So by separation, I mean the head of the humerus here from the glenoid fossa. Others is not so easy. So this is a picture here of the elbow. If you dislocate your elbow, you are in a world of hurt. So some of these, like the more stable joints you have, if those dislocate, you have really caused a lot of trauma to them. The more mobile joints you have, it's a lot easier to dislocate or sublux them because there's not as much stability to them. any sort of contusion or bruising is going to be really fit in two categories. It's bruising is the main cause, or the bruising is a secondary symptom. Now, if, say, someone punches me in the stomach, there's nothing in my stomach that can break. So no bones are going to be broken there. Now, granted, you do have a lot of, different soft tissue in there. But if I bruise something, what is happening? I am getting internal bleeding. So blood vessels inside my body are breaking, causing the bruising, which is actually just bleeding underneath my skin. If I can rule out after getting punched in the stomach that nothing else has happened, so no other internal injuries, my organs are all fine, that would mean that the contusion is my primary symptom, meaning that I just have really superficial blood vessel damage. If you look at something like this here, which is typical of a hamstring strain, if you were to tear your hamstring muscle, you would get really systemic bruising on the entire backside of your leg, but that bruising isn't the primary cause. Like, I didn't just get, like, say, hit in the leg causing a bruise. No, I tore the muscle, and the muscle itself is what's causing that bleeding. So the bruising or the contusion is secondary to the actual tear in the muscle. You can bruise your bone as well. Your bones have blood vessels in them the same way your muscles do. Now, your bones aren't as vascular as your skeletal muscles are, but they still have a vascular system. So you can have a bone bruise. Bone bruises tend to be more painful because you're actually causing a traumatic impact on the bone itself. One of the most common you'll run into in sports is this right here. This is what's called a hip pointer. A hip pointer is a bruise to the lateral side of your superior iliac crest, there you are, iliac spine. Sorry, I had a little bit of a brain loss there. But your entire iliac crest looks like this. And it kind of runs just like this. So your anterior superior iliac spine is the front of your hip. Your posterior superior iliac spine is the back here. And then this middle part where you're seeing this bruising, that's where you're going to get that hip pointer most likely. And that's just going to be the lateral side of your iliac spine. And all that happens here is you get hit in the hip. Most common, this is going to happen to football players. Something like this, there's absolutely nothing you do about it. It's just you play to your pain tolerance. So if you get a bone bruise or a hip pointer and you feel like you could still play, then there is nothing stopping you. If you get a big bruise on your hamstring, most likely because of a hamstring tear, you should not be playing, because if I start, say, running now, I could potentially tear that hamstring even further, causing more damage. There's no more damage I can cause to my hip bone there. Now, sprains and strains. There are many different things you can sprain or strain in the body, but what you're looking at here is a tear. So both of these mean that there is a tear, okay? If you have a sprain, you're talking about a ligament. If I have a strain, I'm talking about a muscle or a tendon. So strains are going to involve muscles and tendons. Sprains are going to involve ligaments. The most common sprain you can have is an ankle sprain, and it's an inversion ankle sprain, meaning you roll your ankle on the inside. If you look at my foot here, if I were to sprain this ankle right here, I would roll that on the inside. This would be called an inversion ankle sprain. When you roll your ankle to this side, the outside of your ankle is what takes on the stress. So the outside of your ankle is going to get hurt. If you do an eversion ankle sprain, you are rolling your ankle inside, and now the inside of my ankle is the one that's getting hurt. If you do an eversion sprain, this is the one that's going to cause more damage. This one is most likely going to result in fracture, and you can also have medial or your inside of your knee become damaged as well, just because of the line it shares of force. The other thing to note with ankle sprains in particular is that ankle sprains are the most common injury you have in sports, and they're also the most common re-injury you have in sports. So if you get an ankle sprain, depending on the source you look, roughly about a 25 to 40% chance of re-injuring that, regardless of the amount of rehab you do or the precautions you take. So an ankle sprain is definitely one of these ones that's a very nagging injury, and that can, last for on and off for a whole season or even a whole career. Now, all strains and sprains are graded on a 3-point scale. A grade 1 would mean that I have a pull of the muscle or I have a slight tear of the tendon. So even when I pull a muscle, even if I pull that apart, I'm still creating small tears in there. So this would be like a micro tear. When I get to grade 2, now this here would be considered a partial thickness tear, meaning it doesn't go through the whole muscle or it doesn't go through the whole tendon or the whole ligament. It's just partially going through it. It would be like if I had a cinder block here and I take a knife and I cut or jab kind of straight into it. It doesn't go all the way through, right? So I still have all this side that's fine, but this side has been injured. So that's your partial thickness tear. When you get to grade 3, you may hear the term avulsion, or you may hear full thickness tear. This is a complete tear. So when you see grade 3, you notice here that there is a complete tear straight away there. You typically don't get grade 3 tears to the muscle belly. You usually only get grade 3 tears to a ligament or to a tendon, because those are very easy to kind of slice off or yank off. If you were to get a grade 3 tear to the muscle belly, it would be an extremely traumatic incident. There would be huge injury to your body. Most likely you're not going to be something like walking around from that. Now, when you have muscle guarding is really just a form of kind of self-preservation or a compensation. Most often, you're going to see muscle guarding in response to having really shoulder or scapula-based pain, potentially a little bit with the leg, but it's very common in the shoulder. If you're an overhead throwing athlete, so if you're like a baseball player, softball player, if you're a quarterback, and you have any pain in your shoulder, if you try to say throw at top speed or max effort, it's going to hurt. Your body doesn't like being hurt. So when you have any sort of muscle guarding, your muscles actually kind of pull back against it, making it so it shortens up your range of motion, and so that you don't have full force available. Your body's trying to make it so you can, if you do that motion, you do it in a compensated way so that you have less pain, but you also have less ability, or you have less functional movement to it. Now, not always does muscle guarding mean that you have a major injury, but it means that there's something wrong with the underlying joint. It could just either be soreness, it could be fatigue, or it could be, as bad as having a complete tear around that area. Either way, when you do muscle guarding, you are essentially contracting or restricting the range of motion you have to prevent future or further injury and to prevent the onset of additional pain. Everyone's had muscle cramps. These are just involuntary muscle contractions. A cramp and a spasm are virtually the same thing, except a cramp They're in the sense they're both involuntary, but a cramp will typically be one solid onset without or with little relaxation, whereas a spasm will contract and relax and then contract and relax several times or multiple times. Usually a spasm is the result of something like, say, a stress fracture to a nearby bone, some sort of injury to the underlying muscle itself, or potentially a nerve issue causing an involuntary contraction of that muscle. When we talk about muscle cramps, many people think that muscle cramps are caused by dehydration. And that's really not the case. If you're dehydrated, you're more susceptible to cramps, but for a reason why you wouldn't think. Many people who get dehydrated tend to drink water with that, which is still good. I mean, it's going to help rehydrate you. But the problem is that hydration doesn't replace your electrolytes. So when you look at these hydration considerations, anything that says hypo means low. And then you look at these here. Natremia refers to Na, which is sodium. Kalemia refers to K, which is potassium. Magnesemia refers to magnesium. And calcemia refers to calcium. All of these are your electrolytes. Electrolytes are responsible for fluid balance. If I'm sweating, I sweat and I release fluids in the form of sweat, which is water, but also in that sweat are electrolytes or salts. If I have any sort of electrolyte imbalance as a result of that, and I just drink more water to rehydrate myself, I'm not replenishing my electrolytes. So my fluid balance is always going to be off because I didn't give myself the electrolytes I needed to properly rehydrate. Now, when you get to the muscular level, because I'm lacking my electrolytes, I can get that involuntary muscle contraction where I maybe voluntarily contract the muscle, but then I can't relax it because I'm not able to get rid of specifically the calcium that is inside the muscle causing the contraction. If I don't have the ability to get my sodium, which is needed to release calcium, if I don't get that in there to release it, that stays contracted and that causes that cramp. A cramp also is greater of a force than what you can provide yourself. It's called your maximum voluntary isometric contraction, or MVIC. When you contract a muscle, like if I flex my bicep here, okay, at best, I'm going to be able to contract that at roughly 80 to 85% of its maximum voluntary isometric contraction. That's the best I can do. And that's the best virtually anyone can do. When you get a cramp, you're up to about 90 to 95% of that maximum contraction. And every one of you knows if you've ever had a muscle cramp, they hurt. So your body puts a governor, or almost like a restrictor plate, like you would see in NASCAR, on muscle contraction because your muscles are a lot stronger than what your body can handle. When you exceed that threshold, if you exceed what that restrictor plate would be, it causes pain. The only way you get to 100% of your maximum voluntary isometric contraction would be if you had tetanus. So if you have tetanus or lockjaw, you have a permanent full contraction. So you can just imagine if a cramp hurts, imagine a cramp, on steroids. That's what tetanus would be like. It's also the only way you can get 100% of your muscle to contract. Now, muscle soreness, or DOMS is delayed onset muscle soreness. This really isn't traumatic per se, but it's a micro tear, or series of micro tears in your muscle itself. That's where you get the traumatic part of it. So when you have DOMS, you have this as a direct result of putting stress on a muscle. You need this because this is what helps make your muscles stronger. When you do like a heavy lifting day, so say it's leg day today, you're going to have really two primary phases that you see of muscle soreness. You have a lactic acid phase and a DOMS phase. Lactic acid is typically going to be your muscle burn. So, feel the burn. This happens usually during or immediately after the workout. Lactic acid really gets rid of itself or recycles itself back into your body within a day at most. If you have some sort of metabolic disorder causing additional lactic acid buildup, yes, that's different. But for an apparently healthy adult, that gets out of there real quick. With DOMS, this is going to happen 24 to 72 hours post-exercise, and this is where you get micro tears in your muscle belly itself. This is why when you say do heavy legs today, I may feel okay tomorrow, but then the day after I feel terrible, like I can't get out of bed kind of thing. That's because your body is trying to heal itself. It's essentially like you have tons and tons of muscle strains on a microscopic level that your body has to heal. The bad thing about it is it causes pain. If you try to do another leg day while feeling sore, you're going to cause yourself to be sore longer, and you're also not going to be able to do as well or be as productive when doing those exercises. But the positive side is if you wait it out and let your body heal, now you get stronger. This is why then the more times you exercise a body part, the less sore you get in the following days, because your body becomes more resistant to DOMS. Your muscles get stronger. Now, nerve injuries, we've kind of gone over these a little bit. You're not going to see too many nerve injuries in sports, aside from like, say, a spinal cord injury. Usually this is going to be some sort of dysfunction underlying. So you usually have some sort of other musculoskeletal dysfunction. The big one you'll see is an ulnar nerve injury. Your ulnar nerve runs on the inside of your elbow. So it comes on the inside of your elbow going down to your pinky side of your hand. So your ulnar nerve is responsible from here, moves your pinky and primarily your ring finger. If you injure your ulnar nerve, this results in having to have, well, I shouldn't say your ulnar nerve, but typically the ulnar nerve is associated with your UCL or your ulnar collateral ligament in your elbow, which is something if you injure, you have Tommy John surgery. So ulnar nerve injuries are probably the most common nerve injury you would see in a non-football environment, but it's usually only going to be restricted to, like, say, baseball players or overhand throwing softball players. Occasionally you would see it in football quarterbacks, but again, that's also rare. Now, that's our acute injuries. Now, our chronic injuries are the ones that last for a long time. With a chronic injury, you are typically looking at something that is overuse related. And overuse means that you just use something over and over and over again. When you get something like, say, a stress fracture here, so you see here we have this nice cut there, there's a little tear there, right here you can see this, but actually right there too. When you get a stress fracture, this isn't the result of like just one bad thing happening. It's a culmination of lots and lots of things. So you're not just going to have your bones break in a stress fracture or have a hairline fracture from really one instance. It's usually repetitive overuse. A lot of times you're going to see stress fractures in the lower spines, the lumbar spine, the knees, the foot and ankle. And most times it's from really running athletes, so especially endurance-based athletes. So maybe basketball players you would look at, definitely track athletes, cross-country or distance runners. They would all be very susceptible to stress fractures. And stress fractures, again, are just where you have a hairline or just a really superficial fracture of the bone. It doesn't come apart or anything, but it's caused from overuse and overloading repeatedly of that bone. Any type of injury you have to a tendon is called tendinopathy. Tendon referring to the tendon itself, pathy referring to injury. So tendinopathy is injury any injury to a tendon. If you have tendinitis, you just have inflammation in the tendon. If you have tenosynovitis, this means that you have inflammation of the tendon and its underlying sheath. So not just the tendon's inflamed, but it's going to be everything underneath it. Usually you're only going to see tenosynovitis in your hand. This is more common in people that have like rheumatoid arthritis. For any of you that are fans of the show The Good Doctor, one of the storylines they just ran is one of the doctors on there has rheumatoid arthritis, and she gets a synovectomy of her hands, meaning all of the joints in her fingers, they went and they cut out the synovial capsule or the synovial sheath of those to allow for more function in the hand. Problem is long term is that has a very poor prognosis. It's really good short term, not good long term. If you injure that synovial sheath, which is the outside of the joint capsule, that's where you would get tenosynovitis. And then tendinosis is just when the tendon fails to heal. So for example, if I get tendinitis, my tendon is inflamed. If I then don't allow that to heal, I can get tendinosis, which is that failed healing. This kind of looks like if I had a tendon here, and then I had all these little tiny tears in it that never healed. That's what tendinosis would look like if I was looking at if this was my tendon. The problem with that is now I lose a lot of the strength and the integrity to the tendon itself. You know, imagine if you say take a piece of paper and you were to, like I say, a piece of loose leaf paper, and you were to rip out certain sections of it that holds itself to the binding of your notebook, and then you try to hold on to that piece of paper, more likely than not, the whole thing is going to fall out. What this means for us is that when you have holes or tears in the tendon itself, it's much more susceptible to injury. So this makes continued healing very difficult. So it becomes an issue over time, and it makes you much more susceptible to having a grade 3 tendon sprain. Now, bursitis, usually you're only going to see this restricted to, say, like the elbow, the shoulder, occasionally the knee. But your bursitis is really just, if you have bursitis, it's just inflammation of what's known as the bursa sacs. So you have a bursa that really lines most all of your joints. And what its primary function is to lubricate the joint, provide some stability and some shock resistance, but this should have kind of the integrity or the consistency of like snot. When you get that inflamed, it actually hardens. So now instead of having like that oozy snot you would out of your nose, now it's kind of like dried snot. It's not pliable. It can actually cause impingements in the area and definitely cause a lot of pain. So when you get this, you typically have to get usually a cortisone injection like they're showing here, and you usually need a lot of rest for it. This is something that just takes a lot of time to heal. Osteoarthritis, you know, again, not something you're really going to see in sports, but this is really just the breakdown of really your joint, or sorry, your cartilage lining the ends of your joints, or your bones, I should say. Usually, if you see this in sports, you see it in the knee, and you usually see it in people that have had multiple knee injuries and knee surgeries. That's usually the only time you're seeing it in, like, especially collegiate sports. In older adults, everyone's going to get arthritis. Just over a lifetime, your cartilage is going to break down, leads to swelling, leads to pain, and leads to dysfunction. Eventually, if you have a complete breakdown of the joint surface where you're what's known as bone on bone, that would require you to have a joint replacement. Most common joint replacements you have are hip, knee, and ankle. Although something like a hip replacement is one of the riskiest procedures to have. It has about a 20 to 25% all-cause mortality rate 1 year post-op, meaning 1 year after surgery, you have about a quarter chance, like a 25% chance of dying after you have that surgery. Now, trigger points are pretty simple. All these are knots in your muscle. So if you feel like you have a knot in your muscle, that is what would be considered a trigger point. In your assignment from last week, when we did the continuing exercise or the corrective exercise continuum, the first phase of that is the inhibition stage. That's where you want to use things like self-myofascial release or SMR to roll out or work out these knots. When you have a knot, what actually has happened here is that you get a muscle fiber that stretches out, and then what's really not showing here is you have fascia lining all of your muscle fibers. Fascia is like a cobweb type connective tissue that surrounds all your muscle fibers and your muscle bellies as well. It acts to give it structure and support. With that, it misshapes, and that's what really gives you that knot feeling. So when you go in and you work out a knot, you're actually reconditioning or repositioning the muscle fibers and the fascia surrounding the muscle. So that's why it hurts, because you are essentially working out what amounts to like a dent in your car. You know, it takes a lot of force to get that dent out. Same way it takes a lot of effort to get a knot out of your body. Now, knots aren't going to kill you, but at the same time, anyone that's ever had one knows that they don't feel well. And the reason why they don't feel well is this knot here is actually a permanent muscle contraction. So that's a big problem with that there. And again, going back to like the cramp example, if you get a cramp, it doesn't feel good. If you have a continuous muscle contraction, it's not going to feel good. Now, I want to finish up here with our healing cycle. When you look at the healing cycle, you have 3 or 4 stages depending on the source. But what this does is it shows you the process of how our body heals from immediately from the injury all the way to years later. When you have an immediate injury, you get this first phase, the acute phase. This is where you have the actual, like say, tear to the muscle, tendon, ligament, bone break, whatever. Usually accompanied by swelling, inflammation. You'll get excessive blood to the area, so you'll get feeling of warmth. It'll be tender. This is when you are most vulnerable here. Immediately after that, this subacute phase, you start to get rid of the swelling and you start the healing process. When you get to the chronic phase, this is where you start getting your muscle fibers or your tissue fibers back in order. And then remodeling will continue really for up to several years. And remodeling is just when all those fibers get back in proper order. So during the first phase or the acute phase, you get inflammation. Inflammation is your body's response to injury. Now, acute inflammation is really good because acute inflammation is going to help your body start the healing process on an injury. Chronic inflammation is bad. If you get chronic inflammation like inside your body, that is a signal that you have really something not right with your overall body process. You have an inflammation factor. It's called PKA, PKA1 actually, I believe. And what that is this is your body's signaling of yourself that you have things that your body perceives as an injury inside you, which really shouldn't be considered injuries. But the more of this inflammation or inflammatory factor that you have, the more at risk you are of developing really bad things such as like strokes or heart attacks, which is what you really don't want. Now, when you first get injured in this acute phase, your range of motion is going to be limited because of this swelling. So swelling is to protect as well as to start that healing process. You don't want to move that particular part of your body. So when you swell, your body naturally limits movement. Fibroblastic repair, this is where you would say get a scab, or this is where the new tissue starts forming. So if I had a cut on my skin and then I get into my initial repair, I have a scab on this. And then as the scab's healing, you'll see scar tissue form on under there. So that scar tissue, for anyone that's had a cut, which is probably most of us, when you get a scar, that tissue looks like more like pinkish. It's a different color, different feel, different texture to it. And it's just because that's the remodeling your body does. Then when you get to this maturation or full remodeling stage, that's where full scar tissue is formed and you're back to being able to kind of return to play there. The thing about scar tissue forming is that scar tissue tends to decrease range of motion. So if you ever get scar tissue buildup, you typically have a loss of range of motion, which usually needs to be worked out as you continue your overall, like say, recovery process. So you can build up scar tissue relatively quickly, but then getting rid of it does take usually a lot of time. If you break or tear scar tissue, it'll usually hurt, but it actually helps to kind of release it from the underlying healthy tissue to then let you experience that full range of motion. Having like a scar tissue break off would be the equivalent of having a scab fall off. And then last thing with re-injury, there's several things that happen that cause re-injury. The big three here: poor rehab, return to play too quickly, and not improving on your compromised mechanics. Now, if you get re-injury from a traumatic event, like say you have a collision, somebody hits you, that's something you can't prepare for. If someone were to hit you in the knee and it tears your ACL, and then you do your full rehab and you go back to play and someone hits you in the knee again, there's nothing you can do about that. So when we talk about re-injury, we're talking about factors that are self-inflicted. So if you have poor rehab, meaning you haven't let the injury fully heal, or you haven't done enough to actually strengthen that area after the injury is healed, that puts you at a higher risk of injuring again. If you try to come back too quickly, so you haven't allowed full healing. So poor rehab would mean you're not back to full functional strength. Not allowing full healing means you still have an active tear, or you have an active fracture perhaps. You haven't allowed the underlying tissue to completely heal. And then the not improving on compromised mechanics, this is kind of the same thing as insanity, doing the same thing over and over and expecting different results. When you don't improve on your mechanics, so like say for a baseball player or a baseball pitcher, if I'm throwing and I tear my rotator cuff and I don't go back and change my mechanics, and I go back to the exact same mechanics, more likely than not, I'm going to re-injure that shoulder. So changing the underlying mechanics of the movement that caused the injury to begin with is something that's going to be needed to prevent future re-injury of that area. So that there is your overview of injuries here. And as I said, we're going to be getting more into these more in depth in the coming weeks. We talk about each of these injuries individually based on body part. But overall, that is that. So thank you for getting through that with me. And I will see you all here sometime later.